and welcome to the Road to Genome podcast. I'm your host, Helen Bethell, Genetic Counsellor and Workforce Development and Education Lead for the North Eastern Yorkshire Genomic Medicine Service, or GMS. Today, I'm delighted to be joined by Emma Groves, who also works for NEY GMS. So, hi, Emma.
Hi, Helen.
Hi. So, can you start then by telling us what is your current job title?
So my title is I'm the Pharmacy Lead for the North Eastern Yorkshire Genomic Medicine Service.
Fantastic. And what does that mean in practice?
So my role is a consultant pharmacist post, and it involves providing leadership to embed genomic medicine into clinical pathways, particularly where there's an intersect between genomic testing and medicines. And in particular, an area called Pharmacogenomics, which is how your DNA impacts response to drugs and medicine.
So you mentioned the term pharmacogenomics. Can you just explain a little bit to our listeners who might not have come across that term before, what it means?
Yeah, so pharmacogenomics is the study of how a person's genome, so their complete set of genetic material, can affect how they respond to medicines. So that's both in terms of effective medicines and also medicines that are safe. And pharmacogenomics combines the fields of pharmacology and genomics and is all about safe, effective medicines tailored to those variations in a person's genes. And it's important to note that variation in your genes is normal. We all have natural variation. And it's estimated that something like 99% of people carry at least one pharmacogenomic variant that could impact response to drugs. Okay. So what we're hoping to do in the principles of pharmacogenomics is you move away from the standard traditional approach, which, the same group of patients will be prescribed a medicine, which is sometimes based on clinical guidelines, but it's very much a one-size-fits-all approach. And you'll go through a trial and error where some patients might have medication stopped or doses increased, doses reduced until you get to the right dose and drug for them. And part of the reason for this variation in response is linked to your genes, but other factors do play a role as well. But what we want to do is move to this pharmacogenomic approach where patients could be offered upfront pharmacogenomic testing that can inform the prescription of the medicine so they get the right medicine for them at the right dose the first time they're treated and remove that trial and error. Yeah. So that's a summary of what pharmacogenomics
sounds incredibly interesting. Yeah. So pharmacy then, is that something that's always been on your radar? Did you want to do that as a child?
So when I was a child, I really had no idea what I wanted to do, but I was fascinated with the world around me. And I was one of those children who would always ask why, but why is it like that? And I think there's maybe not a surprise that I was interested in biology, chemistry, and also philosophy and history for A-levels at school. And then there was a very natural progression, I think, to pharmacy because of my love for chemistry, but really looking at how you can practically apply that science in a healthcare setting to help people.
Yeah. Fantastic. Yeah. And so does it run in the family then? Is there any other pharmacists in the family?
No. So I was the first of my family to go to university.
What were their opinions about you going into a field like pharmacy?
My mum and dad have always been very supportive in whatever path I'd want to take in life. My mum is a secretary and my dad has worked in construction, so they themselves never had the opportunities to do higher education. I think my mum and dad were maybe quite relieved that I chose pharmacy because it had a job at the end of it. So I think
it's an occupation.
They could see that I was doing something that led to a clear career pathway, and I think they were very proud that I chose to do that because I think, although I am a scientist, I was also quite interested in philosophy. Which would have been a very different route to take, but they would have supported me in whatever direction I went in.
And do they take much interest in the pharmacogenomics side of things?
So a little bit about me, and I think you probably know Helen, but I cannot spell. I'm terrible at grammar. It's not great. But my mum has read multiple reports for me over the years, spell checking, making sure the grammar's right. So I think she's picked up some things over the time of what I'm up to. So
yeah, and hopefully they'll listen to the podcast.
Yeah.
Yeah. And did you enjoy your degree?
Yes, I absolutely loved it. Some of my closest friends are still the people that I went to university with.
So what was your journey like then to get into pharmacy?
So my journey into pharmacy was quite what we'd call a traditional route. So I done A-level biology and chemistry at school, and then went on to pharmacy school at Sunderland University, and I graduated there in 2014. And then I went to work in secondary care. So I worked at a local hospital trust, really enjoyed that. And then it was actually when I was a fairly early career pharmacist that I stumbled into a lecture around genomic medicine. So it was a lunchtime learning session that was put on by the trust. And I just thought it was fascinating. And at the end of that session, they were promoting the opportunity to do an MSc in genomic medicine at Newcastle University. And I just thought it sounded like a fantastic opportunity, something that really sang to my interests again around science and how you can practically apply it in healthcare. So I think that was the start of my genomics journey. But intertwined in that, professionally, my career also took me into cancer services. So I worked in Newcastle hospitals in a big cancer centre there, and thoroughly enjoyed that. I was able to really see the cutting edge science applied in practice. So there's so many new medicines, new novel therapies, new drugs that are targeted specifically to genomic alterations in a tumour. And I was able to make the connection from my MSc in genomics around how this was being applied in oncology practice. And then I guess the next step for me was this role as the lead pharmacist for the North Eastern Yorkshire Genomic Medicine Service. And I felt like it had been a role that was made for me, because it was always something that I was trying to do, was bring together my professional practice and genomics.
Yeah, there's so much fantastic stuff in there, Emma. So kind of hearing about your experience of being in clinical practice and being able to find the answers to those why questions, but live and in the field of medicine is fantastic. And it's brilliant that you can like really pinpoint that moment that you heard of genomics and your interest was sparked.
I think it might have predated doing that MSc. I was reflecting on this before the podcast, and I think the first time I heard genetics would have been in biology at school. So we had a lovely biology teacher, and I remember her teaching the DNA bases. So she would always go with Cadbury's goodies are tasty, and that's how you would remember the pairing of the bases. But I don't think at that point I really appreciated that this would be an area that I'd want to go in long term. But it was really in chemistry, I think, that the connections were made. And I remember being taught particularly about cisplatin. So cisplatin is a chemotherapy drug, but the way it works is it's a flat molecule and it slides into the DNA bonds in the DNA, makes connections, and then that means that the DNA can't replicate and can't fold, so killing the cells. And I remember studying that at A-level. And I think that was maybe the moment that I thought, yeah, pharmacy is an area that I'd want to go into because of that practical application. But I didn't think that in the next 10 years I'd be a genomics pharmacist. But I guess those early early interest was there.
And I identify with what you're saying about kind of understanding it right to the molecular level. And I think that's why I love genetics, because I naturally have that why question permanently floating around as well. And I think when you get to genetics, you literally are at the smallest molecular level you can get. And so the answers lie there, and then everything else unfolds as a result of those pathways, but it is at the center of it. So I think as well, I recognise a similar thing from when I did my A-levels, that I don't think genomics, so that for me it was in the late 90s. I don't think genetics was seen as its own discipline in its own right. It was only really kind of being established as a clinical service in that time. So I think very much, it sounds like for both of us during our kind of later stages of our education, genomics was an element to being a part of biology. It wasn't its own discipline in its own right. And it's only as we went further into our careers that we've both explored it, in its own entirety.
Certainly a little bit hidden. We know where we are today. I think, it's a significant part of healthcare. Yeah. It's not something that's on the side.
Yeah. And I think you kind of using that term hidden is really quite key, because I think for many mainstream clinicians currently at the moment, genomics is there, but they just don't realise they're doing it within their practice. So before you took on this genomics role then, which area of pharmacy were you working within?
So very much in oncology. So I'd worked as a rotational pharmacist within the oncology team. Mm-hmm. And as a rotational, it was amazing. So you got to go around all of the different areas. So very highly specialist areas, from pediatric oncology, also various solid tumour groups, also hematology. And there was lots of opportunities when working in hematology to see CAR T cells. So they're in a very novel advanced therapy.
Okay.
So it's quite exciting to be on the ward and seeing real world patients who administered these novel medicines, and they do have side effects and toxicity profiles. So again, a very important role for the pharmacist around not just how you safely administer these medicines, how you store them, but also patient assessment of toxicity and how you manage toxicity and side effects. So I had quite a good experience rotating around the different areas. And then I further developed my passion for research and worked as the lead pharmacist for the oncology clinical trials department there. So again, I think it's really wanting to be at that cutting edge and seeing the drug treatments that are coming through in the studies, which was great. And part of my role was to safely store some of these novel treatments, make sure that they were safely dispensed to patients, and also look at the chemotherapy treatment protocols and design the treatment protocols, making sure that that novel drug was appropriately prescribed within that regimen, that supportive care was there, and very much a patient safety aspect around making sure that their clinical parameters were in range. So things like platelets, white blood cell count, etc., to make sure that they were at the right threshold before drugs could be administered.
So how has pharmacy changed then during your, kind of from your degree to today? How is pharmacy changing?
I think pharmacy's changing significantly. So I think a big step change in terms of the pharmacy profession is more of a focus around clinical work. So I think that some people may have historically thought that pharmacists would put labels on boxes. But there's so much more to the skill set of pharmacists and pharmacy technicians and the wider pharmacy team. And there's definitely been a shift towards more clinical activity and being embedded within the multidisciplinary team. And a big change is independent prescribing. So I did my independent prescribing in 2019, but now from 2026, all newly qualified pharmacists will be independent prescribers. So again, that's a new skill set where pharmacists can actively prescribe for patients. So huge potential, I think, for the NHS to use those skill sets and expertise in medicines. And I think it's going to have to change again. So, but again, it's my passion, but we can see that the healthcare system is getting more and more complicated. Patients are taking more and more medicines. There's more and more adverse effects and complex profiles with some of the drugs. We've got advanced therapy medicinal products, which again are quite novel and complex care. So I think it's keeping a pace with the advances in science and what patients need.
Yeah. And it's absolutely right, isn't it, hearing that, the pharmacists absolutely have a place in that MDT with all those skills and those knowledge, yeah. So thinking back to your clinical work then, Emma, can you think of a case where genomics maybe made a difference?
So I'm going to use my favourite example, which is DPYD pharmacogenomic testing. So I used to work in oncology in a patient-facing role, but part of my job would be to clinically review chemotherapy prescriptions before they're administered to a patient. So I would do a safety check. And part of that check for chemotherapy drugs called fluoropyrimidine, so they're a commonly prescribed class of chemotherapy drug, is that we would check for what we call DPYD. So DPD is an enzyme and it stands for dihydropyrimidine dehydrogenase. So I'll just stick to DPD.
Yeah,
it's quite a big name. So DPD is an enzyme and it's coded for in your genes by the DPYD gene. And the DPD enzyme is involved in the metabolism, so that's how your body breaks down drugs. So it's involved in the breakdown of fluoropyrimidine chemotherapy. But what we know is that some patients don't actually have the enzyme activity in the DPD enzyme to break down fluoropyrimidine chemotherapy drugs.
Okay.
And that's coded for in their genes. So some of these patients who are deficient have increased risk of serious adverse effects. Sometimes toxicity can be fatal because the drug is building up in the body because they can't break it down. The example that I would give is now we screen upfront all patients before they're prescribed this group of chemotherapy drugs, and we check their DPYD gene to predict their enzymatic activity. And for any patients that are identified to have predicted low enzyme levels, then we can give them a dose reduction up front, or we can offer them alternative therapy. So it's all about keeping patients safe.
Yeah, and the benefit for patients is just huge because, if you think of the person that is going through that journey, they're at one of possibly the lowest points of their lives, having to face those kind of treatments, having probably very recently received a diagnosis of cancer. So to be able to offer a test that can, from the outset, indicate we can lessen your side effects, we can make this journey ever so slightly a bit easier for you, is just that impact is huge, isn't it?
Yeah, and I think this is why I love genomics and the potential, because we don't want to be giving patients drugs that are ineffective or cause severe toxicity.
Yeah. It feels like we've been given the key to the lock to kind of opening that door to actually understand all these reactions that people do have to medication, to actually start understanding it.
Yeah. And we're only at the beginning. We're only at the very tip of the iceberg. We've only scratched the surface.
So if we're only scratching the surface, then what is coming down the line?
So in terms of what's coming down the line, I think there's some things in the next, like the near future. And then there's also things that are maybe further down the track.
Yeah.
So in the near future, I don't know if any of the listeners are aware, but NICE have got a diagnostic assessment out at the moment around clopidogrel. So clopidogrel is an antiplatelet drug that is used in stroke. And NICE are actually looking at whether we should be doing CYP2C19 testing. So again, CYP2C19, that is a gene that codes for an enzyme. And for clopidogrel, you need that enzyme activity to convert the clopidogrel drug that you take into its active form in order for it to have an effect. And NICE are looking at whether we should be doing testing because some patients have, again, variation in their enzyme activity. So for some patients, if you don't have the enzyme activity, then you can't take that drug in its inactive form, convert it to its active so that it has the antiplatelet effect. So in terms of what could be coming further down the track and in the future, there are active research programs looking at what we call doing a pharmacogenomic gene panel as part of patient care. So the example I gave with DPYD is looking at one gene and getting information about one gene for prescribing of one medicine. But what we could do is you could look at multiple genes that impact multiple medicines, and you could look at them on what we call a panel all at once. So you get all of that information available in one go, which is amazing to have that. And you know, in theory, you could have this early on in life, and it would be there on your record. Every time you're prescribed a new drug, you could check your pharmacogenomic results. Profile, but there is a really amazing clinical trial that is called Progress. So Progress stands for Pharmacogenomics Rollout Gauging Response to Service. And it's looking at how we could provide an NHS-wide diagnostic service to identify genetic changes associated with many commonly prescribed drugs. And it's led by a team in the Northwest who are leading this clinical trial, and we can circulate some information on it, but it looks very promising. And they're looking at doing this pharmacogenomic gene panel in primary care. So the most medicines are prescribed in GP practices. So I think it's a really good model of how we could use this technology in real world NHS care. So we're really looking forward to the outputs of that research. And I think that'll inform where we go next. So, you know, I'd love to have in the future where a patient comes into a community pharmacy and they show you their pharmacogenomic passport, or you scan a QR code, and all that information's there at your fingertips. So when the pharmacist is reviewing the medicines, they can go, oh, hang on a second. This drug may not be the most effective for you because of these reasons, therefore we're going to give you a higher dose. Or they may say, actually, this drug is very likely to give you adverse drug effects, therefore we'll give you an alternative. Giving patients really like that information.
That power.
I mean, there's still a lot to learn. This science is evolving, and it's like everything, it's got to be taken in context. So pharmacogenomics is not going to be a golden bullet that's going to solve all of our issues around medicine's effectiveness and
of course,
adverse drug reactions, but it definitely can be taken into consideration.
It's part of the picture.
Yeah, exactly. So I absolutely, you still need to look at your renal function, how your liver's working, other blood parameters, blood pressure, etc. But then that extra piece of the puzzle can be brought in, and how your genetics is playing a part in that.
And so kind of hearing what you're describing, it feels almost like there's kind of two sides of the coin, isn't there? There's the point of care decision testing, such as the clopidogrel and the DPYD, where patients are tested when they need to access that. And then there's the element of at which point do we predictively do this? So rather than doing it in an urgent scenario where then there's pressure to get results back quickly, do we do this in a more planned and measured way that we do this, as you say, early in life before we even know whether these drugs will ever be needed, but you have that information in your smartwatch or your fingertips.
Yeah. So that's
when you need it.
So that's what we call it. So we call it reactive testing, which is your DPYD, where you're in a highly specialist cancer setting where you do a specific test. And then, as you said, the proactive testing, where you would do upfront testing in the clinical pathway, and then have it on your record for the rest of your life. In relation to, I know you mentioned there around point of care testing. So there are different models of doing pharmacogenomic tests. So you can do laboratory testing. So you can DPYD is a laboratory test. You send off a blood sample to our genomic laboratory hubs and they do the test for you. But you can also do near patient testing. So that's your point of care diagnostic testing, where there are devices where you could be near a patient, do a saliva swab and put that into the machine, and the machine would be able to give you information about the pharmacogenomic profile. And that's particularly useful when you're trying to give drugs urgently. So there's an example around aminoglycosides. So aminoglycosides are a class of antibiotic drug, very commonly used. But some patients, it's estimated 1 in 500, carry a particular genetic change within their mitochondrial DNA that predisposes them to hearing loss. And there are devices that you could use to test to see whether that patient has that change. And again, the team in the Northwest in Manchester did a clinical trial around using these point of care devices in a neonatal setting. So the clinical trial is called PALO. And again, we can share that with listeners if they want to learn more about that. But I think there's huge potential. So we've got the laboratory testing, which you could look for single genes, or in the lab you could do a panel. You could look at multiple genes, or we also have the point of care testing as well.
Yeah, which is just an incredible amount of science going from, 20 years ago when it was taking 2 years to get any results back, to literally having something that sits in a clinic and throws out a result in 20 minutes. It's just absolutely mind-boggling. So why do you think pharmacogenomics is so important within the NHS setting?
So I think it is a novel area which is growing. So at the moment we're at a bit of a translational stage where we have a lot of evidence base around drug gene pairs, but the translation into practice has been slow. But the reason I think it's so important to invest in pharmacogenomics is we know that in England alone, the cost of prescribing medicines is huge. So I think it's something like over 19 billion in 2022-23, and it's only going up. Medicines are really expensive. They're the second most expensive cost to the NHS after staffing. So if we can make drugs more safe and effective, then there's patient benefits, which are really important, but there's also cost savings to the NHS.
And getting it right first time.
Exactly. Right person, right drug, right time. And again, in terms of value for the patients, if we can avoid these adverse drug reactions, which might be predictable because of genetic predisposures, then if we can pick those people out and give them alternative therapy, then you could be saving bed days in hospital because of adverse drug reactions. I think the data is around 1 in 15 people who were admitted to hospital. It's related to an adverse drug reaction.
That feels high.
Yeah. So although like pharmacogenomics is quite a disruptive thing to implement in the NHS, there are benefits. So I think we need to really continue to drive forward this innovation. And one day, looking at someone's pharmacogenomic profile, just be like, yeah, it's just the same as checking renal function or liver function. We do it every day and it'll be normal. But it's getting to that point, which is exciting to be part of.
So if it's so incredible, why isn't it here yet?
It's a very good question, Helen. And it's something that I ask myself every day and try and think about how we can overcome those barriers. But as I said, pharmacogenomics has huge potential and there is a strong evidence base. But as you say, examples in the real world are quite limited. And that's multifactorial. There's a variety of reasons. Practically, the availability of testing and what's funded in the NHS and on the national directory. So clinicians can't order these tests because they're not commissioned. There's lack of clarity around some drug gene pairs around cost effectiveness. And that's why we need more clinical trials to inform that evidence base. A huge barrier, and something that I'm quite passionate about improving, is the knowledge of healthcare professionals. So if healthcare professionals don't have the underpinning education and training, then they don't know what this result means. So it's really providing that education and training to anyone in the team who's involved in patient care around drugs. And there's so many different healthcare professionals that need to be aware of this. But then also it's that innovation in informatics and decision support. So if you're prescribing a drug and a patient has a gene which impacts that prescribing decision, having a pop-up that says...
Reminded that says...
like, oh, you may want... So I think these pop-ups will probably be information for prescribers, like you may wish to consider an alternative because of X, Y, and Z. But the prescriber, again, will still have to take all of the other factors into consideration. And again, that is an area that is actively being looked at as part of that Progress clinical trial that I mentioned earlier. So it's really positive. But I think it's also working with patients and the public to understand what they need from pharmacogenomics, what level of information they'd like, how their data is stored.
How much involvement they want in that? Do they want to be the ones that, like you say, you mentioned before about physically carrying a pharmacy passport, or actually are they just happy for it to sit remotely on their medical records? How much involvement do the public want with this? How much do they want to know?
And I think every patient will be different.
Yeah, of course.
But again, I just think to like when we had our COVID vaccinations and, they're having a COVID passport.
Yeah, it might be something like that, yeah.
And it gives patients autonomy over their own health as well, and to be involved in that shared decision around what medicines they take and which ones they would prefer to stop or reduce. And
like you say, there were some patients that want to be very active in that, whereas others just want to be told which ones to take. So there is a great variety, isn't there, in how involved patients want to be in understanding that, which I guess is why the work of the patient forum within the Genomic Medicine Service is so crucial to the work we do, isn't it? Helping to try and make sure certainly the work that we're doing with the projects have that patient voice within it.
Yeah, 100%. And again, we can link to some patient information that's been written by colleagues nationally around some of the available pharmacogenomic tests in the NHS. Okay. So there is patient information available, but it's going to be a growing area as well of education.
So we're singing from the same hymn sheet when you were talking about educating the workforce and anyone within the team who has an interest. I think we're of similar opinion there. So what are the particular challenges then with that?
I think the challenge in terms of the workforce and genomics broadly is that it feels like quite a tricky subject to get your head round. It is sometimes hidden, so you don't recognise that it's in your practice.
I agree with you when you say that, it's viewed as something that is complex. And I've been reflecting recently on whether that's maybe a result of the way that genomics has previously been delivered. So clinical genetics was a tertiary service. It was separate and, often physically in different buildings from the rest of the hospital and dealt with as something separate and quite very, very specialist. And so I wonder whether that image still rides. And so people see it as something that is very remote and quite complicated, when in actual fact, as you said, it's actually hidden in a lot of practice and relevant right across the health system.
Yeah. And I think in terms of healthcare professionals and their education around medicines, I think a lot of colleagues will be familiar with pharmacokinetics. So that is absorption, distribution, metabolism, and excretion. So that is what your body does to the drug. And then the other angle is pharmacodynamics.
Mm-hmm.
So pharmacodynamics is what the drug does to the body. So when it has that on-target effect with a receptor to have its therapeutic action, or it can have an off-target effect, which is often what leads to these adverse drug reactions when it's not doing what you intended it to do. So that's routinely taught. But behind those pathways is the coding of the proteins that are involved in these pathways are in your DNA. So if you can understand at a DNA level what's coded for, then that makes the proteins, and then that's what the drug is interacting with.
Yeah.
And then it kind of like, oh, okay, that makes sense.
Yeah. It answers the why.
Yeah. And then we have to be really practical about this as well. So I love that bit. I kind of singing to my why
questions.
But you probably don't need to know all of that in depth. What people really need to have is evidence-based guidelines. So if you're working, for example, in stroke, and you know that there's evidence around clopidogrel and CYP2C19 testing, if there's a national guideline that says patients who have this particular result require this particular drug, then I think that will help the workforce massively. So they don't need to know all of the complicated science. They just need to know what that information means to the prescribing of that drug for that patient.
Yeah.
There will be people like yourself who know more in depth. But for the vast majority of the workforce, I think if we can get to a point where the information that is provided by the laboratory testing or is integrated into the system and the decision support, then I think prescribers will be more comfortable with using this information.
Yeah. So your passion for pharmacogenomics is absolutely infectious, Emma, I have to say. But can you tell us then, on a day-to-day basis in your GMS role, what is the most rewarding part of the job?
I think that's an easy one. So for me, it's working with the really dynamic group of people that we have around us. So all the way from the clinical scientists in the laboratory setting, genetic counsellors like yourself, clinical geneticists, specialist nurses, colleagues working in digital and informatics, communications and how we get the word out around genomics and education and upskilling. Fantastic project managers that have helped with problem solving, working with our patient forum around projects. And I think I've learned so much from working in this really diverse group of people who do think differently to me, but I think that's a good thing. So I'm really focused on the why and the nitty gritty, but then having those people who can see the big picture and the practical applications and what needs to happen next, I think we're a really strong team.
Yeah.
And again, teams, I'd have to talk very highly of the National Pharmacy Network. So I sometimes felt like when I started this role, because it's quite a senior leadership role, that I'd been parachuted in a little bit and was finding my feet. But the network of pharmacists in the different GMSAs and also in national level and in NHS England and also Scotland, Northern Ireland and Wales have been phenomenal. And I think that group of people who come together to collaborate, to share knowledge, and they're also passionate and want to see this happen, that I kind of feel like I'm very grateful to be in the role that I am.
On the flip side then, which bits of the role are more challenging?
I think the bit that's challenging for me is I want pharmacogenomics to be here yesterday.
Yeah.
And that the reality is that translation into practice has to be in a managed way where we're building evidence, applying it, doing those plan, do, study, act cycles, so that we make sure that the services which are implemented for patients are robust, they're cost effective and they're clinically effective. But that does take time. So I just want to go in a clinic tomorrow and have my pharmacogenomic profile and talk to patients about their medicines. But I think that's going to take a little bit longer, but I'm sure it'll be an exciting journey. So it's not so much a negative, but definitely something that I sometimes struggle with is how long we have to wait for cutting edge science.
Yeah. But I guess on the other side of that, it means that you get to enjoy the journey and you get to be right at the centre of it, which clearly you are.
Yeah, completely agree.
So what next for you in your career then, Emma?
It's been a lot of fun so far, and I've enjoyed every step of the way. And I think opportunities, I've been quite opportunistic in the steps that I've taken.
Mhm.
So I think I will naturally go with like what excites me, what interests me.
Yeah.
I think from a professional perspective, I really would like to do more patient-facing activity around genetics and pharmacogenomics, and maybe embed myself more within the clinical genetics team and that wider genetics community. And also what has always been close to my heart is research. And I think that if I pursue a clinical academic career, so maybe as a PhD, a little bit scary, but I think if I push myself in that direction, then I'll have more skills and more tools to think about how you then do this at scale, and have the evidence base to make sure that what we're doing is right for patients. So I see my whole career being very much focused on this area of pharmacogenomics. And I haven't mentioned it really so far, but my role is a consultant pharmacist post, but I myself am not credentialed. So there's a process which is national, and it's very robust, where you have to submit a portfolio of evidence to assure that you're at the right level of practice for consultant pharmacy, and that's managed by the Royal Pharmaceutical Society. So there's 4 pillars of practice. So you have clinical, education, research, and leadership. So I'm working across all 4 pillars and collecting evidence. And, I think I'd hope that at some point I will be a consultant pharmacist in this area as well.
I've no doubt, Emma, you'll get there with flying colours.
Well, now that I've said it on the podcast, I'm going to have to make sure that I submit the portfolio.
Great. Thank you so much, Emma. It's been a pleasure to hear about your passion, not just for pharmacy, but also for genomics. If you would like to hear more information about the topics that we've discussed today, then you can find these on our website, www.ney-genomics.org.uk/podcasts, where you'll also find all the episodes in our podcast series. These can also be found on Spotify, Apple Podcasts, and all other podcast platforms. Thanks for listening.